Hello, everyone. My name is Kim Brawley, and I'm a private practice dietitian specialized in IBD nutrition. Thank you, IBD Club, for the invitation to share this article on avoidant restrictive food intake disorder in patients with inflammatory bowel disease. To provide some context, avoidant restrictive food intake disorder, or ARFID, is a diagnosis that's applicable to individuals of all ages whose behaviors lead to insufficient caloric and/or nutrient intake, and causes at least one of the following burdens: significant weight loss, nutritional deficiency, reliance on nutritional supplements, and/or interference with social functioning. There are three categories that can lead to ARFID symptoms: avoidance of many foods based on their sensory properties, a low appetite or limited interest in eating, and fear of negative consequences such as choking, vomiting, abdominal pain, and bloating with eating. Patients with IBD are at high risk for development of disordered eating patterns due to many factors, some being a heightened focus on weight and weight fluctuations, adverse GI symptoms and inflammation, and dietary restrictions, which may be self-imposed or recommended by a well-intending friend or family. These can often be prescribed as well by the healthcare team. Lack of multidisciplinary team support surrounding these topics is available for patients with IBD. A prevalence of ARFID is 12% to 21% in patients with GI disorders, and 16 to 68% of patients with IBD are malnourished. There's lack of research looking at ARFID and the risks of malnutrition. Our study today was published in the Journal of Clinical Gastroenterology and Hepatology, August of this year. Aims of the study included estimating the prevalence of ARFID, evaluating the risk factors for ARFID, and examining the relationship between ARFID risk and malnutrition risk. This was a cross-sectional study looking at 161 adult patients. Patients completed surveys after clinic visits looking at eating behaviors and nutritional status. Data were taken from the electronic medical records looking at age, sex, race, ethnicity, disease subtype, disease duration, phenotype, medications, surgical history, lab values, and endoscopy findings. Presence of active IBD-related symptoms was defined as having a Harvey-Bradshaw index greater than 4 for Crohn's disease and a colitis activity index greater than 2 for ulcerative colitis. Active inflammation was defined by a CRP greater or equal to 5, calprotectin greater or equal to 250, or colonoscopy findings of inflammation. ARFID risk was measured using a 9-item avoidant restrictive food intake disorder screen, and a total threshold of 24 was used to identify patients at risk of ARFID. Additional survey questions captured food groups that were avoided during a flare and during remission. Malnutrition risk was measured using an adapted patient-generated subjective global assessment short form, and this was based on self-reported criteria looking at 4 sections: weight change, changes in food intake, symptoms and nutrition impact, and activities and functions. The study showed that patients widely reported avoiding lactose foods, spicy foods, alcohol, wheat products, deep fried fatty foods, and caffeine, regardless of symptom activity. 68.3% of patients did not report IBD-related symptoms, while 24.8% had active symptoms. 92% of 161 patients avoided one or more foods in the presence of symptoms, and 75% continued to avoid one or more foods in the absence of symptoms. A positive ARFID risk score greater or equal to 24 was present in 17% of participants. Of those 3 categories related to ARFID risk, fear of a negative consequence after eating scored the highest, followed by picky eating and then poor appetite. Active symptoms and inflammation were significantly associated with a positive risk for ARFID. 29% of 133 patients scored for malnutrition risk, and patients with a positive ARFID risk screen were significantly more likely to be at risk for malnutrition. Strengths of the study include that the topic is relatively unexplored in the IBD population. It suggests an association between ARFID risk and malnutrition. The study evaluates the prevalence of ARFID in an adult IBD population. And it is a good use of the surveys to capture an association here. Limitations are the study design being a cross-sectional study, an inability to piece out symptoms related to IBD versus symptoms that may have been related to IBS. And we know that a large percentage of patients with IBD also have IBS. It was a relatively small sample size, and the surveys did not enable a true diagnosis of ARFID or malnutrition. The survey frequency completed by patients was not quantified or specified. And in my mind, the foods avoided were not significantly nutritionally significant, or in other words, they would not contribute to malnutrition. In conclusion, the study supports ARFID eating behaviors are common among patients with IBD, furthering their malnutrition risk. Researchers from the study suggest to consider screening patients with active IBD symptoms and or inflammation for ARFID risk, and then referring to a dietitian. I would also add referring these patients to a mental health provider who could counsel around the topic. As always, longitudinal studies or more studies surrounding the diagnosis of ARFID and malnutrition are needed to assess prevalence amongst IBD patients. Thank you so much, and I look forward to hearing your thoughts on the topic.